I think, again, the scientific evidence has really changed in the last decade. And now we know that people on long-term opioids don't necessarily have better outcomes. And in fact, they may have worse outcomes. You're looking at some of those outcomes are function. We know that people on long-term opioids don't really have improved function. And we know about the side effects. The side effects that, as we know, 15,000 people a year in the United States die from opioid-related complications. So I think, I think the scientific evidence bears out that there's really now little, in fact, probably very little indication for chronic opioids for pain. We have all of these great alternatives now, and a lot of them involve self-management skills. I really try to break things down into three areas, kind of mental health areas, physical areas, and then medical areas. So when you think of mental health areas, there's been tremendous amount of research where we're actually studying through imaging, neuroimaging, looking at people's brains, giving them specific tasks to do and looking at changes in the brain. Because we know that pain it's really something that's learned. It's learned and imprinted in the brain, and we have the ability to change that. So also physical modalities. There are a lot of physical-based modalities that we can use to treat pain. And finally, non-opioid medication modalities. And again, there's breakthroughs that are coming down the pike and that have happened in the last 10 years, non-opioid types of medications for chronic pain. So some of those, I guess, again, in terms of medications, you can divide those into things like non-steroidal medications, and that's like the Tylenol, the ibuprofen medications. And we continue to refine the non-steroidal medications, trying to be very careful of the side effects. Because some side effects, all medications have side effects. We want to be really careful about those. That's a real challenging issue. And I think, again, putting the patient at the center, when the patient is at the center, really understands the risks of long-term opioids and all of those things that they entail. Most of our patients, are very willing to get off the opioids. The thing is that it's just very challenging. So we have to aggressively treat their pain with these non-opioid modalities, mainly these behavioral modalities, the physical modalities, and the non-opioid medication modalities, and taking things really one step at a time. Little changes beget big changes. So we start with very little changes and we continue to make our little changes, and it's really about not giving up on a patient and really empowering patients, to not give up on themselves. I think that's the key when we're talking about tapering opioids, especially somebody that's been on them a long time. Because when you've been on them a long time, you have chronic brain changes that we then have to help the patient reverse. There's all kinds of changes, and I mean, again, we can kind of structure those into various types of modalities. One would be like cognitive behavioral therapy for pain. One is ACT, acceptance commitment therapy, combinations of those, and they really involve retraining your brain to be able to live pain-free. And we tell people it's not about pain management, it's not about managing it, it's about getting rid of it. You have to remember that in active duty service members, we routinely test for random drug tests. So with that in mind, the rates of abuse are going to naturally be lower. But I think it really goes down to the issue is prevention. And what we're doing in prevention cuts across from active duty members to civilians. So we do our education. We do a lot of activities in terms of education of active duty service members and their dependents and retirees on prescription medication misuse, and it's the same that we're doing in the civilian.